Good afternoon, everyone, and welcome to this afternoon's drug awareness webinar. This is certainly a very important topic that we are discussing this afternoon, and it is a conversation that is worth having. As you are all aware, we have very little knowledge of, some of us have very little knowledge about this topic, but we have formed very strong opinions about it. Nonetheless. And so, today we're going to be addressing some important topics that relate to the laws around drug awareness. So we'll be talking about some illicit and prescription drugs, some effects on the nervous system. We'll be looking at addiction and some of the psychosocial aspects that are related to addiction as well. And so, I should introduce myself. I am Renee Khan, and I'm going to be facilitating or chairing the session. And I'm joined by our expert panelists that include two pharmacists, a psychiatrist, a neuroscientist, and a social worker. And these are very, very renowned academics at UKZN. And so each of them are going to present a short lecture on a designated topic, and that will be followed by questions from our esteemed audience, from our attendees. And so I would like our attendees, if they could, to please use the question and answer icon that is at the bottom of the Zoom screen to add their questions. And as we go through the talks, as our panelists are giving their lecture, then we will address questions as we go through. And then at the end of each lecture topic, we will have a short open question and answer session. And at the end, we will try to put it all together with a series of questions and answers as well. Okay, and so without any further ado, I'm going to introduce our first speaker for today. Our first speaker is Dr. Andy Gray. He's a pharmacist, and he has a keen interest in developing and implementation of national medicines policy, rational medicines use, and in particular ARVs. And he's got a very, very esteemed CV. He's been a fellow and he's an honorary member. He's been chairperson and vice president of various committees and societies, both nationally and internationally. And very, very important is that he even forms part of the review committees and steering groups for the World Health Organization. And so, as you can hear from that impressive CV, that he has a wealth of knowledge on this particular topic. And so, without further ado, I welcome you, Dr. Andy Gray.
Thanks very much, Renee. Good afternoon, everyone. So before I get into my topic, which is on drug policy and regulation and the interaction between those various parts, just a couple of disclaimers. I'm a member of the National Essential Medicines List Committee, and I chair the SAHPRA Names and Scheduling Committee and serve on two of the other expert committees at SAHPRA. But I'm speaking here today as an academic and not on behalf of any official structure. So I'm going to cover national and international structures that impact on the regulation of controlled substances, and I'll explain what those are, and then touch on the national policies with regard to substance use disorder and identify some gaps in implementation in those current policies. In South Africa, we've got overlapping laws that deal with the issue of controlled substances, substances that are subject to international controls and then are subject to national controls. And three different ministers have a role in this. So the Minister of Health, together with the South African Health Products Regulatory Authority, are implementing the Medicines and Related Substances Act. But then we have the Minister of Justice, who works together with the prosecuting authority and the police in implementing the Drugs and Drugs Trafficking Act, and the Minister of Social Development, who establishes another structure called the Central Drug Authority, and they operate in terms of the Prevention of and Treatment for Substance Abuse Act. Each of those has linkages with one another, and they chafe up against one another in one way or another. So in terms of the Medicines Act, if you look at the preamble to that act, apart from providing for the registration of medicines for human or animal use, the Act also provides for the control of medicines and scheduled substances, as well as medical devices. And it regulates who may purchase, sell, possess, dispense, prescribe all of those substances. Scheduled means it's included in a set of lists of substances appended to the end of the Act. And scheduling is done by the minister on the recommendation of the authority, and SAPRA, the authority, relies on the Names and Scheduling Committee to look at the scientific evidence and then advise them, and they then pass on that advice to the minister, and the minister puts those changes into the Government Gazette. For today's purpose, let's distinguish between two categories of substances. Substances that have legitimate medicinal indications, that could be something like codeine or morphine, even cocaine has legitimate medicinal uses. And then there are substances that are considered to have no medicinal uses and which are only used in a non-medicinal way, something like heroin, for example. But as the evidence grows, so we are beginning to reconsider where some substances lie. So cannabis has medicinal properties that can be used legitimately. And so we've moved it towards the medicinal side, the Schedule 6 rather than the Schedule 7. The latest debate is about psilocybin and whether that might have some legitimate uses. The Minister of Justice, in turn, works in terms of the Drugs and Drugs Trafficking Act. And until 2022, there was a section of that act that allowed that minister, after consulting with the Minister of Health, to also develop a list of schedules. Those were not focused on medicines that, for example, can be bought in supermarkets or are prescribed and dispensed in pharmacies. It's only focused on dependence-producing substances, dangerous dependence-producing substances, and then the undesirable. So you'll see that something like morphine might be considered dangerous and dependence-producing, but something like heroin would be an undesirable dependence-producing substance. This has got even more complicated since the Constitutional Court ruled that the private use by an adult of cannabis is something that should not be subject to legal restrictions. And just before the election, the president signed the Cannabis for Private Purposes Act. Once that's brought into effect, once it's promulgated, it will remove all mention of cannabis and the cannabinoids, the active ingredients in the cannabis plant, from the Drugs and Drugs Trafficking Act. So you'll see there that Schedule 2, Part 2 and Schedule 2, Part 3 will be amended to remove those. It also means that people who were previously convicted of possession of cannabis will have those convictions removed from the records. Internationally, South Africa is a signatory to 3 conventions: the Single Convention on Narcotic Drugs of 1961, the Convention on Psychotropic Substances of 1971, and then a convention that deals with intermediate chemicals that are used in the manufacture of narcotics and psychotropics, the 1988 convention. In the same way as SAPRA has a committee that looks at the science and makes recommendations, the World Health Organization has an expert committee on drug dependence, and that committee makes recommendations to the Commission on Narcotic Drugs, which sits in Vienna. It's part of the United Nations Organization on Drugs and Crime. And it adds to the schedules to those conventions. Member states, the signatories to those conventions, are then expected to reflect those changes in their domestic law. We do that in our Medicines Act schedules, for example, and we have to report on our implementation of those schedules to the International Narcotics Control Board, which is also a United Nations function. So what about policies inside the country? I mentioned justice and I mentioned health, but the lead minister in relation to issues of substance use is in fact the Minister of Social Development. And that minister appoints something called the Central Drug Authority, a professional board that looks at these issues, and it develops something called the National Drug Master Plan. Other departments then do sectoral versions of that plan. So there's a health sector drug master plan, and these are expiring this year and next year. The question I want to pose is whether those are coordinated and coherent between one another. The big shift in the current version of the National Drug Master Plan was a move from what's been called the war on drugs, a very punitive, police-oriented approach, to what's called harm reduction. And so the policy document says that it's necessary to form relationships between criminal justice and public health sectors to change laws and support evidence-based harm reduction. And in particular, it highlights the comprehensive nature of those harm reductions. So apart from psychosocial and social work interventions, which we'll hear about later, there should be needle and syringe exchange programs, access to opioid agonist therapy, as well as prevention of HIV and STIs, including hepatitis, and vaccination, TB prevention, diagnosis, and treatment. So combination of factors that brings into play all of public health together with social work. You should see very clear evidence in the health sector drug master plan. And there is mention of improving access to comprehensive management of substance use disorders, including appropriate agonist and partial agonist therapies, particularly for opiates. However, when we go deeper into Department of Health documents and the standard treatment guidelines and essential medicines list, you'll see that in the 2019 edition, there was very little about this. And even the updated version that was updated in 2023 still focuses on the management of opiate withdrawal. And it provides, for example, in moderate to severe withdrawal, for a very short-term access to methadone. And there's just a statement that patients with opioid use disorder should be offered a referral to access opioid substitution therapy or other evidence-based treatment and support. There's no mention yet of long-term opioid agonist therapy, and although there are pilot projects being planned by the Department of Health together with the Department of Social Development, these have really been delayed. And in fact, they're serving on the National Essential Medicines List Committee agenda tomorrow. Instead, most people have had to access, if they could, what's called low threshold methadone maintenance therapy through non-governmental organizations. An example in Durban was the Belhaven Harm Reduction Center. And there is evidence in the peer-reviewed literature of the impact of those sorts of low threshold methadone maintenance programs. So not short-term management of withdrawal, but longer-term ambulatory care involving opioid agonists such as methadone. We probably don't have a good idea of how extensive heroin use is in this country. There's been an attempt to look at the quantities of heroin that are assumed to be consumed in South Africa and then try to extrapolate from that to the number of users. And somewhere between 200 and 400,000 people are using heroin daily in this country. And it's been increasing since the mid to late 2010s. Yesterday, the World Health Organization released its global status report on alcohol and drug use. And I want to just flag a finding there about how few people globally are able to access treatment services for substance use disorder, and how poor the countries are at collecting the epidemiology. So more than 40% of responding countries don't collect data on service provision or the utilization of services by substance use disorder patients. Only 60% of the 145 countries that reported had national guidelines, and you'll see that we've got some guidelines, but they're really not up to scratch. They don't do what our policy documents indicate should be done. And partly that is about getting the resources and the coordination between different departments, and in particular social development and the Department of Health. So I hope that I've given you a short introduction to the complexity of this area and have convinced you that the answer is simply, we've got to bite the bullet. Thanks very much.
Thank you so much, Dr. Gray, for that enlightening presentation. So it's heartwarming to know that, there are people on the forefront that are actually looking to see, that where we can make changes and how interventions can actually assist in this, in our drug awareness and anti-drug addiction campaigns. So thank you so much for your enlightening presentation. Are there any questions? I don't see any questions in the question and answer block, but if there are questions possibly from our panelists.
Thanks, Rena. I'll keep an eye on the Q&A block and see if there are any for later. Thanks very much.
As well. As you were talking, it struck me, given my background as well. You spoke about the fact that the anti-drug campaigns in terms of the availability of things like methadone, etc., are not necessarily being run by the government, but by other organizations. And I imagine that there's also quite a bit of backdoor administration of methadone as well. Is that dangerous?
So methadone is a strictly controlled substance. It is a Schedule 6 itself. So it can only be prescribed by medical practitioners. We don't have evidence of the diversion of methadone. So there's small quantities of methadone. Most pharmacies don't keep it. Most hospitals would have very little of it. And so the risk of it being diverted and being used outside of controlled environments is low at the moment. Compared to the amount of heroin that's used, remember that Wunga and Nyaope, all of these names are just synonyms for low-grade heroin with fillers. There are no antiretrovirals or anything like that. It's just a filler substance to stretch that heroin. However, what we're worried about is that higher potency heroin products are going to enter our market. And what we don't know is whether the synthetic opioids, the fentanyl type products that don't rely on poppies as the original source, might also begin to hit our market, as we've seen in North America and in Europe and Australia. And if that happens, then we're going to have an even bigger problem. Thanks.
Thank you so much for that. We're going to move on to the next presentation. Dr. Andy Gray has actually mentioned some of the drugs that are out there. And so we're going to get Dr. Katie Harris and Dr. Mluleki Luvuno, who's going to be speaking to us about some of the pharmacological actions and neurophysiological mechanisms that are mediated by these particular drugs. So we're going to start with Dr. Katie Harris. She's an alumnus of UKZN. She obtained both her undergrad primary degrees and postgraduate degrees from UKZN. And she is she's a trained pharmacist, having practiced in the pharmacy field and then coming into the academic field, where she teaches pharmacology to undergraduate students, both science and medical students. All the drug in terms of prescribing and also dosage, etc., she's the person to go to. And so, Dr. Katie Harris, we welcome you.
Thank you, Renee. Just figuring out how to move my get my pointer organized. And okay, so I'm going to be presenting on illicit and prescription drugs that cause dependence in South Africa, and try to take you through a whistle stop of some of the drugs. First of all, they are split into, you can broadly split them into 4 different categories: depressants, hallucinogens, stimulants, and opioids. So the most, looking at depressants, these would decrease the activity of the central nervous system, decrease the heart rate and breathing, make you feel relaxed, sometimes sleepy, give you a sense of well-being and euphoria. And most common in South Africa would be alcohol and cannabis being used. Then we've got hallucinogens, which would change your give you a distortion of your sensory, give you a hallucination, and change your mood and thinking, alter your mood and thinking. Cannabis has some of these effects, although it's more commonly thought of as a depressant. And then we've got stimulants, which would increase the activity of the CNS and make you your heart rate and breathing speed up and give you a sense of excitement and euphoria. Things like tic, which is methamphetamine, cocaine, and ecstasy would fall into those categories. Then finally, the opioids, which are a kind of depressant, but grouped together, depress the central nervous system, reduce pain, make you feel sleepy, and heroin and codeine are 2 examples. Right, looking at a population-based study from 2018, just to give us a gist of what the prevalence is like, we've got 4.4% were found to have a past 3-month drug use, not including alcohol. And it was greater in men than in women, so 7.9% in men. And 4% were found to have a past 3-month use of cannabis. Then it drops down to 0.4%. So that's 4 people in 1,000 who are taking sedatives or sleeping pills had done so in the last 3 months. Similar for amphetamine type stimulants, cocaine, and opiates, all at 0.3%. And then inhalants and hallucinogens making up the rest of the drug users. Drug by injection in this study was found to be 0.6% in the past 3 months. Right, and looking more recently at information coming from the last half of 2022, this is data collected from drug treatment centers, people who've sought treatment for their dependence problems, coming together, the data coming together. And for KwaZulu-Natal, there were 12 centers that contributed information, so 1,279 people treated. Of these, just under a third were treated for alcohol dependence, and a very similar number, 28%, for cannabis dependence. And then a fifth of the people were, just under a fifth of people were coming in for opiate dependence problems. And then over-the-counter pre-medication misuse, this would probably be looking mostly at benzodiazepines, so the sleeping tablets, and these would be, it was at 8%, and it had grown from 3% in the previous 5 months. So that might be a growing area to watch out for. Crack cocaine and cannabis mandrax, and methamphetamine and ecstasy made up the rest of the patients or the users that sought assistance. So cannabis, I'm just going to really focus here on the last part, the bottom right of the slide, where I'm looking at the key chemicals, and there you'll see that they I'm sorry, I'm just trying to move this out of the way a bit, are cannabidiol and tetrahydrocannabinol are two main chemicals that have been found in the cannabis plant. There are many others, but these stimulate the endocannabinoid system, which is found throughout the body, and there are these receptors within the system called cannabinoid receptors 1 and 2. These chemicals bind to these receptors and then cause an agonist effect, cause a stimulating effect through that system. Sorry, I'm struggling with my little bars that I want to move out of the way. Okay, so just looking at long-term adverse effects with cannabis, I just really want to focus in on one issue with adolescents and young adults, that it can cause problems with achievement. So, and this happens because of reduced concentration, causing learning problems, decrease in motivation, can also cause impaired judgment, poor social behavior, increase in risk-taking behavior, and a tendency to rebel against authority figures, all of which will lead to problems at school, getting in trouble at school. Also of importance to, and very important to mention here, is that it's a risk factor for primary psychotic disorders and earlier onset of these psychotic disorders. So that's another thing to watch out for. Okay, moving on to the sleeping pills. Benzodiazepines form a large part of this group, and here on the left I've got Valium, which is diazepam, is its generic name, and these benzodiazepines bind to a receptor called the benzodiazepine receptor, and this is found, with this benzodiazepine site, is found on the GABA receptor. So the GABA receptor is a protein that binds to which neurotransmitter GABA binds. Now, GABA is a neurotransmitter in the brain that causes central nervous system depression. So, and it does so through this GABA receptor. So benzodiazepines, when they bind to this GABA receptor, they modulate that effect and make that GABA work even more strongly to bring in chloride ions into the central nervous system, and in this way cause more inhibition of the central neurons and more of an inhibitory depression effect. Okay, looking long term, again, at these benzodiazepines, contributing to being less capable at, doing your daily life things, trying to live a decent daily life. So all of those contributing to problems with that, particularly in the elderly. You're going to watch out for ataxia and falls, which can lead to broken hips and increased morbidity and mortality from that. And also, when if these have been prescribed, they could have been prescribed for anxiety by a medical practitioner, or they could have been obtained illicitly for somebody who's perhaps self-medicating anxiety. But if a person is not able to access these benzodiazepines, or they are trying to move off them, they can get withdrawal symptoms, which can be similar to the original anxiety that they were trying to treat. And so withdrawal needs to be done very slowly over time, reducing very slowly over, reducing week by week. And it could take several months, many months, to finally get the person to be weaned from these drugs. Just again, looking at this slide, here we've got a picture of a, let me just get my pointer here. Okay, so looking here, we've got this GABAergic nerve terminal. We've got these little GABA, these little black balls being the GABA neurotransmitter that's released from that nerve and moving across to the postsynaptic nerve where they're binding to this protein called the GABA receptor. And when they bind there, so this GABA receptor is controlling this chloride channel, so a little conduit for chloride to move through. And when it binds, you see that that channel opens up and chloride can move from, into the central neuron. When you look on the left-hand side, you've got benzodiazepine, these squares that bind, and when they bind to that GABA receptor, together with GABA, you're going to get that chloride, the way they've illustrated here is though that chloride channel opens wider and more chloride is able to get into the central neuron. Actually, what's happening is it's just that it's opening more often, more frequently. And so you're getting more chloride into the nerve, and there's our central neuron, and you can see there's the GABA nerve, the presynaptic nerve there with GABA being released, GABA binding to this receptor in the central neuron. That's allowing chloride to move into the central neuron, and that's going to cause this inhibitory postsynaptic potential to be inhibitory. So it's going to inhibit that central neuron. Okay. Then moving on to Mandrax, also classified as sleeping pill. Methaqualone is its main active ingredient. Diphenhydramine is a antihistamine that was in the original Mandrax that were made by a manufacturer. These are usually illicitly made, so it might just be the methaqualone on its own. Again, these also work at GABA receptors. They also modulate the GABA receptors, make the GABA more available to the central neuron, but that doesn't work through that benzodiazepine receptor. Here's somebody who's using Mandrax. So it's usually smoked, crushed and mixed with dacha and smoked through a pipe or broken bottleneck as a white pipe. Okay, it can also be taken as a tablet or injected. And that's Mandrax. I want to focus on this slide, particularly on the signs of Mandrax use. So you could pick up somebody has been using Mandrax because of, signs to look out for are increased saliva secretion and drooling, and maybe these yellow stained hands from using this bottleneck smoking method, as well as some of the other symptoms there that you can read. Moving on now to the stimulants. Now we're looking at, the others were, had depressant effects in the central nervous system. These are going to stimulate the central nervous system. Methamphetamine, also known as speed and meth, and in South Africa, known as tick in its smoked form. These, then you also get crystal meth, which is a more potent distilled form of methamphetamine, so it would have stronger effects. Tick is sold, it's usually found in these kind of crystals, but you can get it crushed up into powder. It gives you a very intense effect that can take a long time to wear off. And when it wears off, it leaves that user feeling agitated and depressed and wanting to immediately use again in order to avoid coming down from that high. And so ultra-fast methods are used: smoking, snorting the methamphetamine, or injecting the drug. All of these, because they're very quick acting, anything that's quick acting like that will increase the risk of dependence. Swallowing a pill will have a smaller, slower action, so it's less dependence producing. But what can sometimes happen is that a user doesn't get the feeling, the effect immediately, and so takes another a tablet, swallows another pill and another one, and this can risk overdose and death from overdose straight away. So none of it is safe. Relapse rates are high. It's very difficult to work through these withdrawal symptoms and the psychological cravings that come with this drug. I just wanted to highlight in particular one adverse effect here: this increased risk of hemorrhagic stroke in young adults when they take this tick, and it is in this particular study, of people coming in with this problem, a third of these young adults died, and a third of them had inflammation, inflamed blood vessels and hypertension linked to their hemorrhagic stroke. So a very dire consequence. Looking how these work, amphetamines, again, we're looking at these neurons, the nerve endings here, and you can see you've got these little vesicles here, synaptic vesicles with inside there's the little chemicals or neurotransmitters, and meth is this big green ball coming in here, and it gets into that vesicle and kind of pushes out, causes those vesicles or little bubbles to burst, releasing a lot of these neurotransmitters, these little chemicals, which could be adrenaline or epinephrine, norepinephrine, dopamine, and serotonin. And all of these things are then sitting in a synaptic cleft, which is associated with a good feeling, a positive feeling, and also then they can be taken up by the postsynaptic neuron. And you can see here some being taken up. 5-HT is a serotonin receptor, so serotonin's been taken up and causing the positive effect that the person's experiencing. I jumped there a little bit, going back quickly just to say that also besides these, being pushed out, usually these little neurotransmitters are taken back up by the presynaptic neuron, but this is also blocked by these. You can see here's a little transport protein, it's blocked, and so the reuptake is blocked. In the same way that some of the, the antidepressants can work in this way, they block different neurotransmitters from being taken up, and so you have this many neurotransmitters sitting in the synaptic cleft. So that is just to show you how those work. Moving to ecstasy, which is derived from this methamphetamine, it's ND methamphetamine, and it works similarly, but it also, part of the molecule looks like the hallucinogen mescaline, and so it has these hallucinogenic effects as well. It's being used, people use it in nightclubs and raves, where people want to dance all night because it increases your energy and endurance. And then the serotonin effect increases sociability and other wanted effects there. So I just wanted to point that out. At the time, people using it consider it very a safe kind of drug. But it has been associated with overdose, acute overdose deaths, and it can cause permanent damage to the serotonergic system that can lead to, depression. Just here, this ecstasy, just to mention, if it is being used, first thing that's a concern with and why ecstasy does kill is sometimes ecstasy is contaminated and is not pure. So people trying to, reduce harm have suggested taking a quarter of the tablet, waiting for an hour to see if there's been any unwanted effects, and if there's no ill effects, then to take the rest of the tablet and take 500 ml of water per hour to drink that with the drug, and not mix alcohol with it. The way in which ecstasy tends to kill is because it causes hypothermia and you get heat stroke, which can then kill you. And this is worsened with alcohol, which is a diuretic. You also get water intoxication, where the person is drinking drinking water too much because they feel thirsty and hot. And then you get hyponatremia, which can also kill. Serotonin syndrome. So an increase in serotonin will give the drug its wanted effects, that pro-social behavior and empathy and optimism. But, too much serotonin can also push you right over to agitation, seizures, loss of consciousness, and without treatment can be fatal. Then looking at cocaine, again, similar way of working. If you think back to our methamphetamine picture, but this time instead of it, its main method is by blocking those transport proteins, so blocking the reuptake. So once dopamine, serotonin, adrenaline, and noradrenaline are in that synaptic cleft, they're not taken back up and they're by the presynaptic neuron, and they're left there and then are able to bind to the central neurons. You can see that it can be snorted or smoked. I've got the pictures there for you to look at. But moving on from that, just one thing here amongst the many effects, that you can have this crash or severe depression that can come up after 3 days use. And the withdrawal effects can start from 1 day and last for 10 weeks after using cocaine. Also to mention with cocaine is that if you've got, particularly people who have predisposing factors, so if you already have risk factors for cardiac damage, for cardiac disease, you can have a myocardial infarction, sudden, arrhythm, a sudden death from an arrhythm, or a stroke that can kill you. So these are ways in which cocaine can kill. Moving on to opiates, here's the opium poppy, and from the opium poppy you can extract morphine and codeine, which are natural opioids. Methadone is synthetic, so made in a factory, and we'll come back to methadone. Then heroin is a semi-synthetic opioid, so they take morphine and then they chemically process it in order to make that heroin. Heroin binds in the body, works in the body at opiate receptors, which are found centrally, so in the brain, and peripherally all around the body. And there's many different types of these receptors, but the mu opiate receptor is one of them. And the many effects of opiates are that we know of, many of those go through this, when you bind to this mu opiate receptor, you get euphoria, you can get pain relief, analgesia, you can get hypnotic effects, so you feel sleepy and want a sleep-inducing effect. You can also, it's the dependence producing side of things. It will cause dependence and it will cause respiratory depression, which is a very important side effect to know about because it can be the thing that can kill somebody if they have overdosed on one of these drugs. Here is nyaope or wunga mixed with cannabis and low-grade heroin here. And it's smoked, so you get the effect very quickly. As I said, anything where you get the effect very quickly smoked with intravenous injection, you're going to find those kind of drugs highly dependence producing. Sorry, jumped there. Just to point out here, with heroin, heroin can be taken on its own, smoked in by heating and inhaling it, so in a crack form. And also it can be given intravenously injected. And when it's injected, there's the issues of, anytime people sharing needles or open themselves to many more problems because of acquisition or transmission of HIV, hepatitis, the various kinds of hepatitis, septicemia. So that would be where other bacteria have entered, are able to enter the bloodstream and infect the body. Horrible withdrawal effects, which you can read about there. But moving on to this substitution therapy, which Andy talked about. Here's methadone. So methadone originally was developed as a drug which could be used as a cough mixture, opiates, or inhibit the cough reflex. So they're useful if you have a dry cough to prevent that. But it's now mainly used as a substitution therapy. So the idea being that you swap from nyaope or from heroin to methadone, and then that dose would be gradually tapered, either ideally, if you can, to stop it completely, or more realistically, that it's tapered down to a low dose where you can live and, perform daily tasks, in the long term and use it as sort of chronic medication. Buprenorphine is a partial agonist. Partial agonists, so agonists are drugs that bind at a receptor at those proteins, and that's from there you get the sort of triggers a sort of chain reaction of events and cause the effect in the body. So that would be an agonist. A partial agonist, and then you get antagonists where drugs bind to a receptor but block it and stop other things from, being able to work at that point. Buprenorphine is a partial agonist, so it binds at that receptor, but the effect is not very strong. It's not the same effect as if, morphine bound or heroin bound was bounded at that receptor site. And so because of that, they call it a partial agonist. And any partial agonist we think of as part agonist, part antagonist. Part agonist because it's giving you an effect, it's doing something, but it's antagonist because without that, something else might have got in there and done something more, if you like. At low doses, agonists, buprenorphine is more agonist, and in high doses, it's more antagonist. And for this reason, it's useful in detoxification and people trying to move off the opioid dependence. Here's the inhalants. Just to touch on these quickly, you get a whole variety. Nitrates are prescription drugs that we use for angina, and then we've got other hydrocarbons, glue, petrol, paint thinners, and these things are inhaled. They're used by adolescents because they're easily accessible, and they're also used for, by homeless community, street children, and I think very diagnosed because perhaps they don't seek treatment or aren't able to access treatment easily. Horrible arrhythms that can kill you instantly, and serious damage to the brain that can leave you brain damaged. So something to look at, which I'm just touching on here. Then hallucinogens, really, just to touch on these, there's a whole bunch of them, interesting things. LSD, acid, which is also known as acid, mushrooms, there's psilocybin that Andy mentioned earlier, PCP or phencyclidine, and special K, which is ketamine. These hallucinogens act through the serotonergic receptor. So they bind at these serotonergic receptors, like serotonin does, but it's a particular receptor, 5-HT2A receptor, and that gives the hallucinating effect. There's no lethal dose, but they can cause, because you are, you're not experiencing reality, it's distorted. It can lead to beliefs that can cause severe irretrievable psychosis. Okay, so that's one thing. And another thing is that it can cause accidents, self-mutilation and suicide as a consequence of the belief that you have. Could lead you to think you could fly and jump out of a building or something. And also some of these hallucinations can not be good. They can be bad or bad trips, and can be severely unpleasant. My last slide here is just quickly to look at eyes, because it's interesting to have a look at how, these, how you can figure out which drug may be, or give you some sense of what type of drug the person might have been using. Cannabis here is causing red eyes. So cannabis and anything mixed with cannabis, like our nyaope, you're going to see these red eyes. THC is binding to the CB1 receptors in the brain, causing vasodilation, which is increasing the blood flow to the eye, and that's how you see the red eyes. Here you've got pupils dilated, mydriasis it's called, and anything that gives more adrenaline being released, more noradrenaline being released will stimulate adrenergic nerves. So there are receptors for those in the pupil of the eye, and they will cause the radial muscles that are pulling that pupil open to be stimulated, and you get that type of eye. Also, if you've got a drug that's got anticholinergic effect, so these are in the parasympathetic system, the other side of the thing, where these kind of neurotransmitters stimulate the circular muscles, in the pupils, and cause them to contract. So bringing down the size of the muscle. So something, so when those are blocked, when you have anticholinergic drugs, then that system is blocked, and so you get this mydriasis instead. Opiates here cause meiosis, which can be a way of can be something that we look at to know that something that people look at to recognize opiate use. And that's the end of my slideshow. Thank you very much.
Thank you so much, Dr. Katie Harris. So yeah, it did go a little bit over time, but I allowed it to happen because we were getting an education. So thank you so much for that. we've heard a lot about these drugs. We hear about them all the time, and I'm coming from Wentworth. So, you know, there's always somebody saying something about somebody who's addicted. And it's so nice to know exactly what is happening in that particular individual as they are exposing themselves to these substances. So there's still no questions in the Q&A box, but what interested me, I've got just two questions, is that on one of the slides right at the beginning, you were talking about the prevalence in women and in men, but you didn't mention children. And, you know, recently we've been hearing a lot about children being addicted to some of these substances, and then mixing different things together, cough mixture and cool drink and whatever else. Is there any information about the prevalence of the use of these addictive substances in children?
So I'm not sure in that study, I didn't really look carefully to see how they had separated, you know, if they just put people into male and female, and from what age, what the youngest age was in that study. But I haven't got figures for children, I'm afraid.
Yeah.
Very
I think it will
interesting
be
though.
so interesting to see, you know,
Yes.
especially given within these communities, especially the lower income communities, you see kids dropping out of school, etc., and we don't know
Yes.
what's actually causing those. And it would be interesting to see if it
I
had to
think
do
the second slide I had, where the information was coming into the group that was looking at, you know, where they sought treatment, and they're coming in from treatment centers. You know, what they're trying to look at, they've got several different goals, but one of the things is to try and see trends and changes. So it will be, you know, they will have, I didn't look at their ages for those, you know, 1,000 people that had come in to KZN facilities, but they do have it available. And so there, you know, there are, there's a nice app that Andy actually shared with me, which goes into all the data that's available, and they're trying to make that more shareable as well, so that people know where they're at, you know, and then we can see whether any interventions make a difference or not. So I think it is out there. It's just maybe I haven't found it yet.
Thank you. Maybe it'll come up later on as well.
Yes, maybe I can answer it later.
Yeah, because also the, you know, as you were talking about the acute effects, because somebody exposes themselves by taking a particular drug, it crosses the blood-brain barrier, and it has all of these these effects relatively quickly, because
Yes.
it can cross the blood-brain barrier quickly. But any idea of what the chronic effects are? So are there association with chronic diseases because of the long-term use of drugs?
Well, yes, it would depend on the drug you're looking at, but definitely, because if you think of those stimulants, for example, you know, when you are, because they're not, those little neurotransmitters aren't allowed back into the nerves, you know, you're depleting your presynaptic neurons of neurotransmitter. The body can make more, but it's going to mean that, you know, you can't then have a natural high as easily. You know, you're losing your ability to, and many of the drugs have that, you know, have that effect of not being able to, and you know, drugs, the way they work too is that you have, the body adjusts to that, and maybe our psychiatrist will explain that more, but how the actual receptors upregulate, and you end up with more of them, and so you need more of that particular neurotransmitter to fill up a certain proportion of them in order to get the, you know, get the high that you're looking for. So it can kind of sort of rob you of, you know, a natural joy that you could have, you know, as I understand it. Yep.
But that is very important to mention. Thank you so much for that, Katie.
Thank you.
We are going, so there is another question about vaping. Is it dangerous? Is it addictive? Because a lot of kids are actually into their teenagers, young adults into the vaping at the moment.
So I think, again, it would depend on what substance they are vaping. You know, if you are using, and perhaps if Andy's around, maybe he'll jump in and say more. But I would say yes, they are less dangerous and addictive than, say, you know, if you're using tobacco, than a cigarette, but they still do have damaging effects, and they still are dependence producing, as I understand it.
Okay, Andy?
Yeah, if we look at what are called electronic nicotine delivery systems, or ENDS, the classic vapes that you can buy. The evidence that they're safer than tobacco is an extrapolation from the fact that you are not lighting something. And so the carcinogens that are present in the tar released from tobacco might not be present. However, there are other chemicals in those vapes that have long-term consequences, and we don't know what all of those are. However, if it's nicotine, it's going to be as addictive, because nicotine is a really addictive substance. It's also incredibly toxic. So nicotine in its pure form, especially vapes that are refilled with nicotine liquid, that nicotine is dangerous and easily can overdose a child. Nicotine can penetrate right through the skin transdermally. So it's a very, very nasty and very addictive chemical. And in fact, it's probably more difficult to get off of nicotine than it is off of many other addictive substances, including alcohol.
Thank you very much for that. I'm sure that later on we'll be able to have more of a conversation about that, but let us move on because time is going. We're going to move to Dr. Luvuno now. Dr. Luvuno is a neuroscientist. Well, he's a physiologist who has specialized in neurophysiology specifically. And part of his research after he obtained his PhD degree has got to do with the effects of diet on brain performance. And so I'm sure that now he's also going to enlighten us about the effects of drugs on brain performance as well. So he also looks at other diseases, chronic diseases like cancer and diabetes, but he looks at Alzheimer's, schizophrenia, HIV, and other cognitive disabilities as well. So without further ado, Dr. Luvuno, if you can share your slides. Thank you.
Thank you, Dr. Rene, for introducing me. I am trying to find my slides here, but I can't seem to. Let me go straight to documents or show all the windows.
I can share them for you.
I found them. Thank you. Let me see. I have already started sharing. Can you please confirm if my screen is visible?
Your screen is visible and we can hear you clearly.
Thank you so much once again, Renee, for introducing me. Katie mentioned something that when you do cannabis, your eyes turn red. So I gotta mention that my eyes are red, but disclaimer there, I'm not into cannabis. Okay, so part of the things that I will be talking about, can I switch off my screen? Okay, so I will talk about drug addiction, the reward pathway, which is normally hijacked during drug addiction. I will also look at some mechanisms for few drugs and how the brain responds to dopamine levels. I think Katie did touch on the adverse effects of the drugs, so I may not dwell much on that. All right. Normally, when we see these people who are addicted to drugs, we sort of judge them as people who do not have a purpose in life. And we even have names or connotations for those people. Things like names like this one is Ipara, you know. So in society, we sort of push these people away due to how we perceive them and our judgment towards them. But in actual fact, they are having a serious chronic mental disorder, which is normally characterized by compulsive drug-seeking behavior. And they continue to use drugs despite significant harmful consequences. So it is a really, really serious condition that they are going through. Unfortunately, when you are deep into the drugs and you are very, very addicted, it is not really easy to get out, even if you want. So we really need to change our ways in terms of how we view these people in our society, and less stigmatize their mental disorder. So how does drug addiction occur? Normally, it starts with experimentation, where you try different drugs. It could be due to peer pressure, or you're one of those people who like things, you know, and you try to use the drug, right? And then you enjoy the high that you get from the drug, which is normally referred to as euphoria. So then you keep on taking the drug in repetitive fashion. And then there is where it gets risky. So what happens is that the drug take over your system, and then it drives you away from your family. It drives away from your friends. So it affects relationships. But more importantly, it also affects your daily responsibilities. So if you are an adult and you are working, it is going to affect your work life. If you are still young, probably it will affect your school life. I think Katie did touch on that in terms of how it affects kids at school. And then over time, your body will depend on the presence of the drug for its normal functioning. And then you will find yourself in this deep pit of addiction, where you continue to use the drug despite the harmful consequences from the drug. So in our brains, we have a reward system, which is normally evolutionary-wise, it is a survival pathway. All animals, including humans, have used it to seek food, water, as well as to procreate, to ensure that there is a continued existence of a species, in this case, humans. So this is a really, really very important pathway in our brain, which allows us to survive and keep the existence of our species going on. But when we use drugs, they come in and hijack this pathway. So you take the drug in into the system. It will find itself in the bloodstream, whether you inhaled it, drank it, swallowed it, injected it. So it will find itself in the bloodstream, and it will cross the blood-brain barrier and find itself within the brain. And this is where it matters the most when it comes to drug addiction. And the brain is where you find the reward pathway, which I have mentioned that it is the pathway for survival. We need it for our daily life so that we are always motivated to get up and seek food, water, and so on. So once the drug is in the brain, it will go to a brain area in the brainstem, which is known as the ventral tegmental area. And this is where dopamine is being synthesized and will be released. So the drug will then activate dopamine release from the VTA area. When this dopamine is released, activate the accumbens. Now, this is a very important area in the brain in regard to how we perceive rewards, pleasure as well, because our rewards make us feel good. Rewards make us feel good. So this is the area that is associated with perception of rewards and pleasure. So the drugs will go and dopamine released due to the drug will go and activate the nucleus accumbens, which will allow us to perceive the reward that comes from taking the drug. So because now there is abnormal or abnormally high levels of dopamine, we are going to feel a strong feeling of euphoria due to the drug. But apart from this, dopamine also goes to other areas of the brain. One of them is the prefrontal cortex. Now, this is where reinforcement of the drug happens, where the body will now encourage us to seek the drug and keep on repeating drug intake. There are other brain areas that are involved in this pathway. One of them is the amygdala, which is associated with moods. This is where serotonin comes in. So the drug will be able to modulate moods as well through dopamine. And the hippocampus forms memories. So now we can associate the environment with the drug usage. So if you use the drug when you go to the club, every time you go to a club, you will want to use the drug. If you use the drug when you chill with your friends, every time when you are with your friends, you will want to use a drug, right? So now there is this increase or surge of dopamine in the brain, and again, it makes one to have a strong feeling of euphoria. So they are very, very excited, but very, very happy, but in an abnormal way, something that the natural rewards will fail to do. And the last part that happens is the cravings, compulsion, or compulsive behavior, where you now crave for the drug. Normally, it happens with the withdrawal symptoms. Katie did touch on that. It comes from the mostly the hippocampus, because it forms memories So every time when you see something that associate you with drugs, you will start to crave drugs. So it could be you are seeing your friends, it could be you're seeing a place where you used to chill with your friends. So you may start to have those cravings. Katie did also touch on different drugs. So I'm just gonna look at a few of them here. Normally when one takes cocaine, what it does is that it prevents dopamine reuptake. So when that happens, there will be a lot of dopamine trapped in the synaptic cleft. And these high levels of dopamine in the synaptic cleft will then produce intense feelings of euphoria. But again, it will require high doses for one to achieve the same effect that was achieved with a previous dosage. Cannabis also it has different names, dacha, marijuana. It has a lot of names, street names. It works through the CB1 receptors that are expressed almost everywhere in the body, but particularly in the brain, it will activate the CB1 receptors, which will indirectly increase the release of dopamine from the ventral tegmental area. And over time, the use of weed or marijuana will require more of the drug for one to achieve the same effect. Nyaupe as well, it has been mentioned. Some call it wunga. It is a mixture of heroin and other things that may be toxic, like ARVs, detergents, and so on. So this is a combination of drugs where you have heroin and cannabis as well. Normally when you combine two drugs, they call this a speedball. So now is sort of a speedball. You have two drugs and B1 receptors and increase dopamine. But in addition to that, now you see when it is in the body, it will be receptors.
It seems that we have lost Dr. Luvuno. I still see his name in the panel.
I'm back. I just
You're
noticed that I got
Okay.
kicked out.
Great.
Let me try and share my slide again.
Dr. Luvuno, if you can also just be aware of time.
Can you please remind me where I was with my slides?
You were on slide 5.
Slide 5, yes.
Yeah.
So there is a combination, synergistic effect of heroin and cannabis. And all these drugs will develop physical and psychological dependent, which the colleagues have alluded to. So how does the body, let us look at how these drugs increase dopamine levels compared to the natural rewards such as food, and sex, you can see that heroin and meth, they increase dopamine levels more than 5-fold times compared to the natural rewards. And then what happens is that the brain has to now respond to these abnormal high levels of dopamine. And one of the ways in which the brain responds to this is by inhibiting a release of dopamine from the dopaminergic neurons. Another way of doing this is to increase reuptake of dopamine and degradation of dopamine. And the last one is when the body decides to downregulate or burn out the dopamine receptors. And because there's abnormally high levels, it normally burns up to 80% of the dopamine receptors. And this can explain how one develops tolerance. There's repeated drug use, where which will then make the brain reward system to become less responsive to the drug because of how the brain responds to abnormal high levels of dopamine. So to maintain the levels of dopamine, the brain will again reduce dopamine receptors and so on. And because of these changes in the brain, there will be a need for a higher dosage of a particular drug to achieve the same effect. So what this does is that it then increases drug overdose and can lead to serious health complications, which Katie mentioned almost all of them. The first graph looks at the healthy brain. So when you eat food, this is how dopamine responds to food. So you have a normal spike of dopamine, which then will return back to baseline levels. But when you take the drug, let us say for the first time you take cocaine, it is going to increase dopamine to significantly higher levels. For instance, we can say it would increase dopamine to 900. But then what happens after that is that when one wakes up, they'll wake up with a new baseline level. So the new baseline level would then shift the graph down in terms of how the spike of taking cocaine will cause in dopamine release. So when one takes the drug again, it will start from a new baseline level, which is further below that of a normal person or a healthy brain. So it shifts the graph down, and as a result, it then lowers the feeling of the degree to which one feels pleasure when they are taking the drug, and it will compel them to take more of the drug. So this will then lead to dependency. Dependency is when it normally happens when the brain is now, in terms of response, there is a very, very low number of dopaminergic neurons. So it fully depends on the drug for normal dopamine levels. So when the drug is not present in the system, then one cannot function normally. So what will happen then is that they will be compelled to go and take the drug to up the dopamine levels, which were very, very, very low after the drug was removed from the system. So during the time when the drug is removed from, is not present in the system, this led to withdrawal symptoms and strong compulsion to to take the drug. And I hope that it answers one of the questions that were posed to Katie. This graph here shows different types of the drugs, and my colleagues mentioned almost all of them. So it shows dependence in relation to physical harm, heroin being the most dependable and causing very, very serious adverse effect compared to other drugs. My colleague Katie also talked about how it can affect our body. So just to summarize what has been covered, the decreased dopamine production will reduce pleasure from the previously enjoyable activities. So the person that is addicted to drugs will not find pleasure in normal things like food. And also it will impair the function of the prefrontal cortex, making one to have poor judgment and having the increased risk to continue the drug despite negative consequences. It also impairs the amygdala and the hippocampus, which are associated with cravings and potential relapse. It does have an effect on the heart, where it causes heart attacks and abnormal beatings of the heart. And again, drugs that are inhaled normally will affect the lungs, which can lead to chronic pulmonary conditions such as chronic bronchitis. And the drugs that are normally injected will increase the risk of conducting infectious disease such as HIV and other bloodborne infections. So the risk factors that are normally associated with addictions include early use, peer pressure, stress and trauma. So people normally use these as coping mechanisms. There's who lack self-control. So those people are more susceptible to using drugs, and some people they are risky in their behavior, so it increases the chance of being addicted to drugs. So for us to protect ourselves against drug addictions, we got to have some goals, which include total abstinence from the drugs, educating ourselves and increasing awareness, and also having a strong support system. And lastly, to develop healthy coping mechanisms. And all this will allow us to sort of have a strong stance against drug addiction. And thank you, colleagues. Let us all say no to drugs.
Thank you so much, Dr. Luvuno. So I'm going to just see if there are one or two questions. They're not coming up in the Q&A, so I'm wondering if they might come up in the chats. Just one question or two questions, because we are running short of time, so we need to be cognizant of that as well. Well, if there's no questions, I think maybe let's go to, yes? Okay, I thought I heard someone saying something. We're going to go to Dr. Hemant Nobath. He's a psychiatrist in private practice, but he is an alumnus of the University of Natal, because that's where he got his specialty at UKZN. And so he's also the founder and president of the South African Addiction Medicine Society. And so he's going to tell us a little bit about addiction. And I think that it will probably cover a bit of what Dr. Luvuno said as well, but I think it's just going to concretize it for us. So welcome, Dr. Nobath. You may share your screen.
Okay. Hi, good afternoon. Can you hear me? Can you see me?
We can hear you and we can see the top of your head.
The top of my head.
Oh, no, that's worse. Can just bring you.
And now,
Nope, nope, that's worse.
is that better?
No, that's worse. And no, I can't see you, Dr. Noban.
Yeah.
Maybe pull your, there you go. That's better. Yeah,
Is that okay?
that's okay. Yeah.
Okay, thank you very much. Thank you for the introduction and for the invitation to speak here today. The advantage of speaking at this stage is that much of what I'm going to say has already been said and covered by various speakers. So I can be quick and take you on a quick flip through this. It probably ties up most of what has been said. I must point out at the outset that I'm not an academic, but I come from the real world of work. And, where's my, can't I click this down just 1 second? I can't flip my, oh, there we are. Now it's working. And what I do on a daily basis is I see patients. And I'm going to introduce you to a smattering of these patients. The first is a 45-year-old man who drinks a bottle of whiskey every day. He's been doing so for 3 years, and despite damage to his liver and deterioration all around in terms of loss of his job and family, he continues to drink. The young lady who uses 80 to 100 still pain tablets a day. Now, still pain is an analgesic that contains codeine, and even though it's a Schedule 5 substance, it's freely available from most pharmacies without a script. We've talked about cannabis. The adolescent who starts using cannabis at the age of 12, 13 gravitates to wunga, which is effectively heroin, and then presents floridly psychotic and requires admission to hospital. The 38-year-old medical specialist meets an old school friend, has 2 glasses of wine, and then disappears on a Thursday on a cocaine binge and only rocks up back home on Sunday. Patient loses 80,000 rands in the casino in 2 hours. And then finally, the most interesting of people, a 50-year-old man who has a wife, but in addition, has 9 girlfriends. I honestly don't know how he manages. And he has children who range in age from 3 months to 27. All these people suffer from an addiction. If you belong to my generation and you did Latin at school, you'll know that addiction comes from the Latin addictio, which simply means to enslave. This has been covered. Psychiatrists like classification systems. The DSM-5 is the 5th iteration of our diagnostic and statistic manual, and that was published in 2013. There's subsequently been a text revision to that. Many of you, if you look at the substances on the side, would have started this morning with a cup of coffee or 2. Some of you, I presume, will have, when you get back home this evening, a glass or 2 of wine or double whiskey. A few of you will use a painkiller containing an opiate. Very few, I hope, will use a hypnotic in order to fall asleep tonight. If you look at the list, the addictions can be divided into the legal substances, alcohol, tobacco, the sedatives, the analgesics, and obviously the illicit substances. And with DSM-5 in 2013 came the first recognition of a behavioral addiction. That's gambling disorder. There's also criteria being developed for compulsive shopping, mainly in women, internet addiction, and sex addiction. Slide that just sums up what we've been talking about. Why are we concerned about addiction? Why are we concerned about the problem? First, there's the impact on the individual, physical and mental well-being, the inability to work, to live a productive life. There's a breakdown in family, relationships, finances. There's a cost to society in terms of the costs of treatment, and also the fact that lots of petty crime and some serious crime is driven by addicts trying to fuel their habit, fund their habits. We thought tobacco smoking post the hard lockdown was on its way out, but we didn't reckon with the well-connected illicit nicotine cigarette lobby. A third to half the people who smoke will die as a result of their smoking, and tobacco consumption is the leading preventable cause of death today. Dr. Harries and Dr. Levuna have touched on the diagnostic criteria which we list in DSM, so I'll just flip through this. It's spending a significant amount of time to obtain a substance or to recover from its use, failure to fulfill responsibilities, continued use despite problems in interpersonal relationships, the effect on social, occupational, and recreational activity, use in physically hazardous situations. And then we've spoken about the craving, the development of tolerance where you need more of the substance to achieve the same effect, the onset of withdrawal syndrome when you stop using the substance, failed attempts to reduce, and the use despite awareness that the substance exacerbates a physical or psychological problem. Withdrawal can be physical and psychological, marked by irritability, anger, being anxious, insomnia, dysphoric mood, impairment, attention, concentration, memory, and the most severe consequence of delirium, especially seen with alcohol, a delirium, an acute confusional state caused because suddenly stopped using the substance. And that's a dangerous medical condition. There are many different models of addiction. There's a legal model, which simply says, it's illegal, it's against the law, don't use it. There's a moral model. This religious text says it's a sin to drink, don't consume alcohol, don't smoke cigarettes, don't use a drug. Psychological and sociocultural models, which have been spoken about. But in medicine and in psychiatry, we work on biological models, where we see addiction as a complex, chronic medical condition more than anything else, driven, as you've seen, by changes at a receptor level in the brain. I talk about dual diagnosis here. Between 40 and 80% of patients with a substance use disorder will have a comorbid psychiatric illness. That may be a depression, an anxiety disorder, a personality disorder. Then we divide this into the substance use disorders and the substance-induced conditions where cannabis may induce a psychotic state or alcohol induces a mood disorder. It's important to make that distinction because that determines treatment. And hence I've included that beware a rehabilitation facility that only focuses on the substance of abuse and ignores the underlying psychiatric condition. What about cannabis? It's been spoken about already. The only people who don't like weed have never tried it. And in this context, I must point out that in the 70s and the 80s, when everybody on campus used cannabis, the concentration of THC sat between 1% and 3%. Today, with genetic modification, with hybrid strains on the market, we see cannabis sitting with THC concentrations between 27 and 29%, going up even higher than that. In the last year, I had a patient who used designer cannabis 150% THC. He was admitted floridly psychotic for 4 days. And what many people don't realize is that cannabis causes significant risk, physical risk. I've had two 25-year-olds using cannabis 3 or 4 times a day for a year. One presented at 25 with a sudden stroke, the other presented with myocardial infarction. So it's dangerous. Oh, this is a marker to introduce behavioral addictions. On this here, you see young people. I was sitting at a social function a week ago, and I saw people my age around a table while this function was going on, all on their cell phones, replying to WhatsApp messages, playing chess on a cell phone, and trying to catch up with social media. As I said, gambling disorder was acknowledged as an entity in 2013 with DSM-5. They're gambling-related cognitive distortions. Gamblers think they can control an outcome which is determined by chance. They can predict what's going to happen on a roulette table. It's said that a big win is what catches you. And the big win is equivalent to a year's salary. And that varies from person to person. Who's that in the middle? The golfers will know Tiger Woods. And what addiction did he have? These bevy of beauties around him. Tiger had a sex addiction. And when that emerged, he got hit on the head with a 9-iron by his wife. Tiger Woods never won a golf tournament for 10 years after that. The dangers of addiction. A brief word on treatment. There must be a recognition that addiction is a medical problem. Treatment must be holistic, it mustn't be judgmental. It involves both the use of medication, psychological treatments. Many people add a spiritual dimension to this. And addiction, I've always said, is the one area in medicine that is truly multidisciplinary. It brings everybody together: psychiatrists, psychologists, family practitioners, addiction counselors, physiotherapists, biokinetists. It's a whole range of people come together in a team, and everybody's an equally important member of that team. Psychosocial treatments are there, and I'm not going to talk in depth about them, but to mention the invaluable role that support groups play. Things like the AA, Alcoholics Anonymous, Narcotics Anonymous, Gamblers Anonymous. The only grouse I have with them is that they believe in abstinence as a model as opposed to harm reduction models, but that's another debate. The use of medication. What do we have specific treatments for? Only a few substances. The opioids, we have methadone, we have buprenorphine, and the buprenorphine naloxone combination. And in our state facilities today, we still don't have methadone or buprenorphine available, despite the fact that in 2013, the World Health Organization determined that both those drugs ought to be on an essential drugs list. We still don't have them available. I even struggle to get them for patients in private practice. For alcohol, there's acamprosate, there's disulfiram. Nicotine, there's varenicline in its new formulation, and bupropion. And for the benzodiazepine, for the overdose, we have flumazenil. There's no specific pharmacotherapy for the rest of the substances of addiction. All we do is use a range of different psychotropics, the anxiolytics, the antidepressants, the mood stabilizers, the neuroleptics, to contain and to control patients. Because there's nothing specific. We must consider, when we're treating, the personal beliefs of the patient, our own prejudices, our own countertransference. What emotions has a patient aroused within us? We must address fears that patients have. We must look at personality. There are a host of barriers to treatment. We don't have resources, we don't have drugs, we don't have people. There are very few people who are trained to use OST or opiate substitution therapy. There are few resources in KZN, and I think we have one state rehab center. There's a stigma that's already been spoken about. Patients don't want to see a psychiatrist, don't want to admit to the addiction. People are not aware that there are treatments available. Social circumstances, money, finances, all inhibit treatment. In an ideal world, we're looking at trying to provide a service that's available, that's freely accessible, that's affordable, and a service that must be supportive and must be one in which we form a therapeutic alliance with patients. We have in the area of addiction in this country as a whole host of unmet needs, and we're only touching on the surface of it. And that's why chats like this are important to spread the word. Thank you very much for your attention.
And thank you, Dr. Nobath, for such a brilliant presentation. Although it also touched on some of the molecular and physical aspects that have already been addressed by Dr. Harris and Dr. Luvuno, it also brought to the fore the people aspect. And I think a lot of time we forget about this as a human being, and he has a role in his family, or his or her family has a role in society, in the community. And so you brought that in a bit as well. And it was nice also to, make us aware that there are other addictive things besides drugs. So thank you so much for your presentation. In the chat, I see that Dr. Luvuno says that a psychiatrist's perspective is a good one. So he says that he's worried that if there's anything that can be done to prevent cases of relapse after rehabilitation therapy, given that most addicts, they get hijacked by these drugs with no hope of recovery. So can you respond to that, Dr. Nobath? Dr. Nobath, yeah.
Okay,
so
I've unmuted myself. Yeah, relapse prevention is a debate on its own. The point about treating any kind of substance is that we first aim to get the patient free of the substance, recognize that this is a chronic problem, try to keep the patient in remission for as long as is possible, and then limit both the frequency and the intensity of the relapse. Now, we often struggle to do that because we return patients to environments in which they don't have resources available. I want a patient to be on methadone or Suboxone for at least 12 months after discharge. Patients can't afford that. Medical aids don't pay for that. The social environment to which the patient returns is important. So there's a host of triggers, the stresses out there, the comorbid psychiatric illnesses. All these factors play a role in relapse. And this is why it's important for, to stress that patients post-rehab attend outpatient support groups, come in for treatment, maintain regular contact with people, but often with patients, it's difficult to do that. The pilot program that Andy Gray and Monique Marks were involved in at Belhaven was an excellent program. It showed, that OST does work. It pulled patients and people off the streets, but it could only fund the initial stages could only fund treatment for about 50 people for a limited period of time. So it's all a question of resources availability. That's the problem.
So possibly we need to just redefine the problem, make petition government to be aware of how bad the problem is and how it needs intervention, just as much as our non-communicable and communicable diseases need intervention.
Absolutely. If only government would listen to people on the grounds, but they're deaf. So,
well, we have Dr. Andy Gray, who has connections. So
let's use them. Let's use them.
You've had a lot of congratulatory messages about an excellent presentation, and indicating that rehabilitation and aftercare is critical. And then also asking about support centers and programs that are available for our students.
Yes, certainly. The university does offer programs. You can make contact to them, to the Department of Psychiatry. At another level, there's SADC, the South African Depression and Anxiety Group, which offers a service as well, not just for addiction, but for a whole range of mental illnesses that are there and that are available. It's, the first step is getting people to acknowledge there's a problem, then getting them to come forward and seek help and seek treatment. It's always been a problem for us. But yes, there are, we have few resources, but people can actually have access to them. Campus Health will give that to you, and they'll send patients across to the Department of Psychiatry for treatment.
Absolutely. Thank you for that. So we have our student support services at UKZN who are very hands-on in terms of identifying issues as well. As Prof. Kuresha has raised as well, the linkage to organized crime and money laundering does need some kind of intervention as well. I think, when you lower that reward, then you are going to have less people buying into that, because for criminals, that is their support. So we need to look at that as well.
It's a huge, big issue that is not being addressed, as Professor Abdul Karim says correctly. We need this. I mean, but if you look at this, the illicit cigarette lobby was so politically well connected, at that level, and it works. Outside there, if you look at the UN, UN Doc Services that Dr. Lochanaid is involved with, is only touching on the surface of what's going on. And you're fighting big business, you're fighting a lot of money, you're fighting organized crime. Where does it start, and who's there who's going to confront all this? Even at a local level, the local police are protecting drug lords in the townships. They're on the payroll. We know that.
Yeah.
People know what you live in. We talk about Wentworth. I work in Phoenix. People can point out where the drug dens are, but nothing's being done.
Absolutely, yeah. So yes, so our justice department also does need to come to the party in order to stop this problem, this epidemic that has developed actually in our country. So thank you so much. We're going to go to our last talk by Prof. John Langba, and he's a social worker, and so I think that he's going to take us very nicely into the social aspects as well. Also has a very, very impressive CV in terms of the fellowships that he has, and connections in terms of the different committees that he works with. But also he's the founding director of the College of Humanities Doctoral Academy, so he has a special interest in academic progression as well. So welcome to you, Prof. Johannes John Langba. Thank you.
Thank you very much. Can you hear me, Rennie?
I can hear you, and I can see you well.
Thank you. Just a disclaimer, apologies. I am sitting in for a colleague who was supposed to present, and she's unfortunately unwell, and she sends her apologies. Thank you very much to the College of Health Sciences for inviting not just me, but the social work discipline to this webinar. I mean, not often we get invited to this space, notwithstanding the fact that the problem of addiction and drug, should always engage in a systemic approach. And Dr. Nobat, it's like we compared notes before we came here. You've covered a lot of the social aspect that I'm going to talk about, but I will just and focus on the social work implications. But just to say that when there's a contribution around access to services for our students, actually the South Africa Depression and Anxiety Group is now located at UKZN campus on Shepstone building there. So we give them a space there. So students actually have access to that as well. But there are within the vicinity of the university as well, private programs that students can access. But thanks, like I said already, for the introduction. I also sit here as someone who represents UKZN in the KZN Provincial Anti-Substance Abuse Forum that was established a couple of years ago, I think before COVID. So we were involved in the last 2 years to develop the drug master plan, which entails looking at demand and supply issues that Dr. Norbert has alluded to. My brief was to talk about the social aspect of drug and the social work implications. So I thought, let me talk about the effect of substance use disorders on individuals, families, and society, and the implications for our practice as social work. So by way of outline, obviously I can't talk about substance use disorder. I'll probably, preaching to the choir, but I thought I would just talk about what substance use disorders are and what are some of the examples of substances that can lead to SUD and some of the symptoms which the colleagues have already covered. But more importantly, the effect of substance use disorders on individuals at the individual level, at the family level, and the society and community level that Dr. Norbert talked about. And what are some of the common social work interventions for SUDs, and then conclude with some final thoughts. And again, as social work as a profession, we also study and use the DSM, the DSM-5. But I'm going to use a definition by the National Institute of Mental Health in the US that says, substance use disorder is a treatable mental disorder that affects a person's behavior and brain, leading to their inability to control their use of substances like legal or illegal drugs, alcohol, and some medications. So the symptoms can be moderate to severe with addiction, which Dr. Norbert clearly articulated and what that means, and addiction 101. Addiction being the most severe form of substance use disorder. So what are some of the examples of substances that can lead to SUD, substance use disorders? People can use substances occasionally without developing SUD. However, a few episodes of taking certain substances can lead to tolerance and dependence, which Vuno talked about. And the colleagues have spoken about them: tobacco, heroin, cocaine, alcohol, cannabis, benzodiazepines. These are all examples of substances that an individual can develop tolerance and dependence on. What are the symptoms of SUDs? The symptoms are usually associated with they fall into 4 major categories: impaired control, social impairment, risky use, which is sometimes overdose, and pharmacological criteria like tolerance and withdrawal, which can be profound. So now the effects of what are some of the effects of and I know Dr. Norbert talked about the cost. In the behavioral science, we talk about the impact or the effect. The effect of SUDs, right, are numerous. They can be medical, they can be psychiatric, they can be psychological, spiritual, economical, social, and impact particularly in the family and especially children, and there are legal problems as well. So the SUDs create a significant burden for not just for the individuals, but their families and also society. And again, like I said, it's as if the previous speaker, we compared our notes. So the effects are usually known to occur at 3 levels: at the individual level, the person living with SUD, at the family level, and the societal community level, which as social workers, that's where we focus. We focus on these 3 levels. So let's start with at the individual level. And again, like I said, I probably speak preaching to the choir, but individuals living with SUD may also have other mental health problems, right? And they may struggle with substance use. And some of these mental disorders that are associated with with substance use are anxiety disorders, depression, ADHD, bipolar disorder, personality disorders, schizophrenia. And these are some of the common comorbidities with substance use disorders, among others. But however, although people that have SUD, right, can have a comorbid mental disorder, that does not necessarily mean that one necessarily causes the other. But like Dr. Nuba said, you can't look at one without looking at the other, but not necessarily, in terms of causality, one causing the other. There are other biological issues that can lead to that. So the effects of SUDs on individuals, right? They can have other mental health disorder, obviously, and people with mental disorder can also struggle with substance use. So the common risk factors that contribute to both SUDs and other mental disorders, what are they? SUDs, like other mental disorders, SUDs in the DSM, can run in families, meaning that certain genes may be a risk factor. There are environmental factors as well, such as stress or trauma, that can cause genetic changes that are passed down from generation to generation. And they can contribute to the development of mental disorder or a substance use disorder. Now, there are lots and lots of research around this. Dennis Daly and others. Some of us have done research on this. A lot of studies have found that people with mental disorders such as anxiety, depression, PTSD may use drugs or alcohol as a form of self-medication. So although some drugs may temporarily help with some symptoms of mental disorder, they may make these symptoms worse. Brain changes in people with mental disorders may enhance the rewarding effect that we talked about of substances, making it more likely that they continue to use the substance, the dopamine that Luvio so eloquently described. That's the individual. What are the effects of substance use disorders on the family? This has been widely documented in a lot of research. There's, without a doubt, an adverse effect of SUD on the family system, including the individual that's living with SUD, particularly also children. So SUDs actually affect a lot of people within the nuclear and extended family units, in addition to the individual with the problem. And this creates a burden for the family and its members. Some of the effects of SUDs on the family unit may include emotional burden. Members may feel anger, frustration, fear, worry about the individual. There's also the economic burden, the cost, right? People losing their jobs, reliance on public assistance. As social workers, those are some of the things we try to ameliorate. Relationship distress and dissatisfaction are also some of the effects. Families may experience high rates of tension and conflict that are related to the use of substances. We all know SUDs can also lead to family instability, abuse, violence, family breakup, separation, divorce, and unfortunately, the removal of children from the home. There is also something that is, I think, another effect that is prevalent in South Africa, the effect of using substance, especially alcohol, on developing fetus and children. A lot of research, in South Africa, in the Western Cape, where there was, a high prevalence of fetal alcohol syndrome, can harm the fetal development, causing birth defects. It's documented. It's the evidence is there that, especially alcohol, when you use alcohol during pregnancy, the likelihood of the child developing fetal alcohol syndrome is high. There's a lot of research in the US, even in South Africa, that infants born to upward dependent mothers at increased risk for neonatal abstinence syndrome, which can contribute to developmental or cognitive delays. What about children of parents with SUDs? They are at increased risk for abuse, behavioral problem, and eventually use substance as well. There's a lot of evidence that mothers with SUDs may show less sensitivity and emotional, not just mothers, but parents as well, both that. Let me put it that way. Parents with SUDs may show less sensitivity and emotional availability to their children. They may feel, guilty, helpless, frustrated, angry, depressed. Those are some of the effects on the family. What about the social or societal effects of SUDs, substance use disorder? I mean, it's a known fact that they impact on the social functioning of individuals. And that creates a burden for society as well. Dr. Nobat alluded to that. I mean, the comorbidity that he spoke about, they contribute to medical and psychiatric conditions, disability, and death as a result of accidents. In South Africa, we have a very high rate of road accident, higher rates of suicidality. Those are some of the costs to society. But there are other social costs and social problems or societal effects, housing instability, homelessness, HIV transmission due to IV drug use, high-risk sexual behaviors, unemployment, people lose their jobs. But more importantly, especially with the high crime in South Africa, criminal behavior, victim or perpetrator, and eventually incarceration. A recent study we published in the International Journal of Drug Policy, where we used data from Sweden, the Swedish registry data. We investigated immigrant background, incarceration history, and recidivism among adults assessed for illicit drug use in Sweden. What we found we concluded that, well, the main finding really was among individuals assessed for illicit drug use within Swedish municipalities, those with immigrant backgrounds face higher incarceration risk, even after controlling for substance use severity and prior incarceration. So in that article, which was published this year, actually, with colleagues in Sweden and the US, we concluded that tailored interventions and support systems are vital to prevent re-entry into the criminal justice system for illicit drug users. So timely actions can break reoffending cycles, redirecting, the pathways from reoffending and towards legal reintegration. But what was really troubling was with this study, when we compared immigrants, especially young people of immigrants, especially from Africa who are living in Sweden, and Swedish-born adolescents or young people, right? Children with immigrant backgrounds are higher risk of incarceration. That's a finding for another discussion. But it's important to know some of this fact that especially when we are tailoring interventions, and that can apply to South Africa as well. What are some of the common social work interventions? I mean, social work responses to, substance use disorder, we focus on non-medical interventions that are focusing on the family, the individual, and society, like I said earlier on, because family interventions, for example, can help the family influence and pressure the individual who actually enter treatment. So we involve the family. Yeah. So the family is involved, and we work with the family, we support them to get the individual to seek treatment. And by so doing, we address the impact on the family system. So what we do as social workers, we support the individual and also support the family to address their own reactions and problems associated with their loved one living with SUD. There is a considerable literature support that's supporting that when you work with couples and family, right? It's called the couples and family approaches to addressing SUD, intervening SUD. It may reduce the emotional burden for family members so they can cope effectively with the situation at hand. Yeah. I was going to ask, I mean, when you know, you usually go last, there are pros and cons. Renee, how much time do I have?
I was just thinking that I'll give you another 4 or so minutes so we can close. We are
Okay.
running overtime already. But yeah, it's
Yeah,
only
that's
give you a few more minutes. Yeah.
that's the cons when you go last. You don't have a lot of time, but sometimes, you know, there's a pro, you have a lot of time. But I'll talk a little bit about what we do as social worker and how we help families and the individual living with SUD. So we encourage and support families to engage in the care of their individual. They should be involved, and we support them. It's not easy to be involved, but we support them to get involved. We also facilitate education about SUDs as social workers. And the support for, you know, for family treatment, you know, not just the individual, but when they are educated, they would more likely influence the individual to seek treatment. So as social workers, we focus on that as well. We also focus on reducing the emotional bonding on the family. Like I said, I mean, family members experience a wide range of emotions when, you know, such as anger and anxiety and depression about the issue, especially when it's a loved one or even a child, a teenage son or girl. More importantly, we also help the family to support the individual living with SUD. How do we do that? We help the family engage in the recovery to meet their own needs. So they support the individual. They also have their own issues as well, and we support them. Social work interventions also focus on children. I mean, especially in families where there's a child and either one parent has SUD or both parents. So what we do is we help them understand the impact of SUDs on children and examine how children may have their, you know, harm to the children may be reduced. I mean, we talk about harm reduction in treatment, but we also support social workers, families to reduce the harm where there's a lot of abuse as well. So we encourage parents with SUDs to talk with their children about their impact on their family and the children, and try to, you know, assist them to maintain an open dialogue with the children to address their feelings and questions and concerns and not be angry and start abusing the children. Right? We also recommend and we work on behavioral interventions as well, what we call behavioral therapies, and we utilize that a lot. And the common ones, I mean, you know, you know, some of the most effective ones of behavioral therapies for adults, right? And particularly for adults with co-occurring mental disorders, you know, cognitive behavioral therapy, CBT, dialectic behavioral therapy. I mean, this we can explain. We have what we call assertive community treatment. It's a form of community-based mental health care that emphasizes outreach to the community and an individualized treatment approach, right? There's this concept which I understand was in South Africa, but not so common anymore. I was in Australia a couple of years ago. I visited one of the communities called therapeutic communities, where there's a whole community like a complex where people in recovery live. It's a common form of long-term residential treatment that focuses on helping people develop new and healthier values and attitudes and behaviors and return to either first, you know, when they exit the program, they find them a job and they try to keep that job. And there is also contingency management, you know, what we call CM. CM principles encourage healthy behaviors by offering vouchers and rewards for desired behavior. But, you know, these are all have been tested. We need to do research and see how effective they are in our context. So some final thoughts on, you know, the effect of SUDs on families, individual families and communities, and the implications for social work practice. So like I've just said, SUD's impacts on individuals, right, and families and society. The SUDs actually create challenges for individuals in treatment and in family, sorry, and for society. There are many effective interventions out there. And there are mutual support programs in South Africa. I mean, we talked about AA, NA, and so that help individuals and their families. But how could families help? I mean, the take-home, message here, how as social workers, we recommend that families can facilitate their involvement. We facilitate, we support families to get involved in the treatment of the loved one, right? We encourage them to provide support and attend sessions together with the individual, right? We encourage them to engage in ongoing discussions about recovery and what cannot be done to help the individual not relapse. But we educate and point out early warning signs of relapse that their loved ones may ignore and help them stabilize from a relapse point of view so that relapse does not occur. Thank you again very much for inviting me. I hope this has been useful to bring in the social and behavioral aspects into the conversation. Thank you.
Thank you very much, Prof. John Langba. Yes, it's absolutely essential, I think, to bring in the social aspects. And I identified with a lot of the things that you said. One of the comments from Dr. Luvuno that I also identify with was the fact that, that it can be passed down, this addiction issue can be passed down through the generations. And I've seen it with alcoholic syndrome babies, and how as they grow up, they also tend towards substance abuse. So yes, I think that it is an important conversation. I don't think that we have enough social workers to actually deal with the enormity of the problem that we are facing. But I think that it's a start just to to let everyone know that, there is the social aspect that needs to be dealt with. Prof, I have heard a saying that sometimes you just need to let the addict go, let them hit rock bottom, and then they will recover. When they hit rock bottom, they will make a decision one way or another. Do you agree with that approach?
No, I don't. I mean, people need to be supported. People, especially if they are in recovery, but the impact and the cost, it's about opportunity cost here. The impact of, letting them go are huge as opposed to the benefits of letting them go. So I necessarily do, and I've had it as well. Especially what I've just mentioned on just not just, self-harm, but on the family and society. The costs are huge to not address or support the person living with SUD.
Yes, thank you so much to all our panelists. If all our panelists can just put on their video at this present time so we can see you, and thank you. So thank you to every single one of you. You have all educated me today, and I'm sure that it has been an education and not only to our other panelists, but also to our guests and the other attendees as well. So thank you so much. It's yes, we know that drugs are a problem, and so this webinar was absolutely necessary. And as scientists, we know about it from the, the aspects of at the molecular level and the physical level, etc. But it was so nice to also take it to the personal level, to the community level, family level. So thank you so much to everybody for your input. And thank you very, very much to CHS for organizing this webinar with specific emphasis to Lunga, Mamela. Thank you very much, and God bless you all. Take care. Bye-bye.
Thank you.
Thanks, Renee. Bye.
Thank you.
Bye.
Bye-bye.
Thank you. Bye.